Hello, I'm your host today, Michelle Winokur. Welcome to our webinar today, The Challenge of Primary Prevention. All right. Again, I'm your host today, Michelle Winokur. By training, I'm an epidemiologist, but I've spent my most recent years working in nonprofit management and now have the pleasure of serving as IAS's chief executive. In that role, I have the privilege of working with our members around the world, and at this time, I'd like to introduce you to the experts for today's webinar. Dr. Peter Libby is a cardiovascular medicine specialist at the Brigham and Women's Hospital and the Mellencroft Professor of Medicine at Harvard Medical School. Dr. Libby is a board certified in internal medicine and cardiovascular disease. He's the author of some 400 original peer-reviewed publications, more than 450 reviews, chapters, or other publications, and he also serves as an editor of the leading textbook of cardiovascular medicine. Dr. Libby's clinical and research interests include vascular biology, atherosclerosis, and preventive cardiology. He's an award-winning researcher and past president of the International Atherosclerosis Society. Joining us from Italy today is Dr. Manfredi Rizzo. He is a professor of endocrinology at the University of Palermo and director of the Diabetes and Cardiometabolic Prevention Unit at University Hospital of Palermo. He holds several adjunct professor positions and is editor-in-chief of the Journal of Diabetes and Its Complications, and he is president-elect of the Central Europe Diabetes Association. After several years on IAS's European Regional Federation, he is now a member of the IAS Board of Directors representing Europe. Dr. Viviane Rocha is a cardiologist at the Lipid Clinic of the Heart Institute at the University of São Paulo, Brazil. Dr. Rocha is a member of the molecular cardiology team at Grupo Fleury as well. She has been the administrative director of the atherosclerosis department of the Brazilian Society of Cardiology since 2012. And after several years of volunteering with IAS last year, she was elected by the membership to join the executive committee, where she now serves as secretary. So welcome to all of our experts. We have a great panel today, and I know they look forward to sharing some great information with you. Before we get into that, I want to take just a few minutes to share a brief introduction of the IAS for those who may be unfamiliar. The International Atherosclerosis Society is a nearly 50-year-old organization that brings together the world's leading experts in atherosclerosis and related cardiometabolic conditions. We focus on developing mission-centered programming like this webinar, and we focus on efforts that reach across geographical and generational boundaries. This slide represents a map of our global reach. IAS represents more than 40,000 healthcare providers around the world who are active on their own individually or via one of IAS's 65 member societies. This map is constantly getting updated with new individual and society members being added. So if you're interested in learning more about joining us, please visit our website at athero.org. I also want to share just a little bit about today's discussion. It's rooted in the content of IAS's recently released Clinical Proceedings White Paper, which is shown on the screen here and downloadable at the link there, athero.org, in our resources section. The paper has 6 main sections as shown on the screen, and each will be touched upon briefly today. If you have questions, feel free to drop them in the box below the video playing on your screen right now. There's a Q&A box, and we'll take up those questions in the course of our conversation today and during the discussion section that Dr. Libby will lead at the end. And then I just have one more slide before I turn it over. I want to recognize, even though I've already introduced Drs. Libby, Rizzo, and Rocha, I want to acknowledge the other authors of the white paper. Dr. Raman Puri from Italy and Didi Zhao from China also contributed to the development of the paper. And I also want to share that IAS received unrestricted educational support from Aspirion Therapeutics and Mylan Inc., which is a Viatris company. So these grants help to support the development of the white paper and this webinar. And with that, I would like to turn it over to Dr. Libby to lead us off.
Great. Well, it's a pleasure to participate in this. And we're going to start out by reminding everyone that the foundation of cardiovascular prevention beyond lifestyle is the concentration of LDL. It determines the onset as well as severity and progression of this disease. And so it's a causal lifetime cumulative risk factor. But we'll get into other risk markers that are very important as we go through this. And, we have to confront the many gaps in screening, diagnosis, and management of elevated LDL cholesterol and other risk factors. And that's what we're going to be dealing with in the next 45 minutes or so. And that white paper that is available at the athero.org website really summarizes some of the proceedings and thoughts that we're going to be dealing with here today. Now, as I think about prevention, there are a number of paradoxes and challenges and hurdles. As a matter of fact, there's tension. I'd like to highlight a few of these matters, and we'll come back and discuss them at the end. And we'd love to have your input into how we might resolve these. So we're sitting atop a growing and incredibly rich palette of proven preventive therapies. Yet, we're facing a great deal of challenge in getting them implemented, and each environment has its own challenges to implementation. And, we've gone through an epidemiologic transition with the global waning of communicable diseases. Chronic diseases, such as atherosclerosis, have risen. And so people are living longer, but they're not necessarily living better. We have increased lifespan without concomitant health span. We have an expansion of morbidity due to the chronic diseases. And this is a very important issue for those of us involved with the International Atherosclerosis Society, with the wide reach that you just heard from Dr. Winokur, because cardiovascular disease is on the rise in low and middle income countries. Now, this is from the book that I helped to edit, the textbook of cardiovascular medicine. And what it shows in the upper row is that in 1990, cardiovascular disease was counting for only about a fifth of death in low and middle income countries. But at the next time slot depicted here, 2017, it's almost a third. And it has now come into parity. If you look in the lower right pie, come into parity with the high income countries. So we have a global pandemic that we have to deal with. And this is very much the concern and brief of the International Atherosclerosis Society. Now, these are data that I pulled up from the Global Burden of Disease website, and I'm sure that your 11-year-old child could do a better job than I did of graphing it. But what this shows is that in high-income countries, there's been a gradual decline in cardiovascular diseases, but with an unsettling uptick, as you see, in recent years. Whereas low and middle income countries have consistently increased in the number of deaths due to cardiovascular disease, really illustrating the global reach of the problem that we're dealing with today. Now, that critical transition point happened in 2006. And what I'm very concerned about, and this precedes the COVID-19 pandemic, there's an uptick in 2014. And unfortunately, it seems as this is continuing. So our concentration on prevention is ever more important. And the reason that the greatest burden of cardiovascular disease resides in low and middle income countries is because of the numbers, the denominator. As you see here, there are tens of millions, hundreds of millions of people that have cardiovascular disease, and a great burden of this disease is outside of Europe and the United States. Now, there's another issue that I view as a tension in prevention, and that is one way to deal with primary prevention is to use a poly pill. So a combination of ingredients and distribute it widely so that one size fits many. But then there's a tension with the move towards personalized or precision medicine, which aims to give the right drug or right intervention to the right person at the right time at the right dose. So how can we have a one size fits all, but then precision on the other side? And that's another issue which we can discuss. And yesterday I was in clinic all day, and I heard several variations of, but can I do this with diet and exercise? Do I really have to take another pill? And we have the problem of pill burden and polypharmacy to deal with our patient population. And then there's another tension that I'd like to put on the table for us to consider and discuss. And that is primordial prevention, which is really taking primary prevention to the very young part of our population and start risk modification early to limit lifetime risk. But then there are guidelines, your guidelines, our guidelines, guidelines all over the world that tend to allocate treatment later in life based on 10-year risk assessment rather than lifetime risk. So how do we square that circle? So just sort of to sum up, cardiovascular disease has gone global. It's no longer just a problem of the highly developed countries, the market economies. The worldwide spread of obesity and attendant diabetes threatens public health with a wave of premature cardiovascular disease. And I'm particularly concerned about our youth. They're very vulnerable with childhood obesity and with type 2 diabetes having transitioned to be the majority of cases of diabetes in youth versus type 1. We really have to face a communicable disease pandemic. So how do we actually measure risk when we're trying to allocate therapies? Well, there are biomarkers. And one biomarker that has really emerged since the pandemic made the installed base of assays very large is interleukin-6, a pro-inflammatory cytokine that we know is causal in cardiovascular disease. And these graphs are a little too small for you to read, but they're from a very recent analysis led by my colleague, Dr. Ritker, where he looked at the women's health study and followed them up for 30 years and measured three biomarkers, LDL, Lp(a), and the biomarker of inflammation, C-reactive protein, measured with a high sensitivity assay. And the family of curves on the left shows that for each of those three biomarkers, there is a stepwise increase in risk over 30 years as we stack different quintiles of this particular panel of biomarkers. And on the right, you can see that it really applies to all kinds of cardiovascular disease. So whatever kind of cardiovascular disease you're looking at, these three biomarkers tend to sum up an awful lot of risk. We'll hear more about that. But what do we do about the young who are, as I've mentioned, at great risk? Well, here we can think about using genetic markers. We can use polygenic risk scores, or PRS, which look at the contribution of a large number of variants of rather small effects that can determine your lifetime exposure to risk factors. These are much more common than the monogenic diseases such as familial hypercholesterolemia or other genetically determined Mendelian traits. And so perhaps we can use polygenic risk scores to assess an individual's risk for cardiovascular disease from youth. Actually, since you inherit these variants from mom or dad, it can be actually in utero. And here's just a statement from the American Heart Association. I'm sure different regions have different statements about the use of polygenic risk scores. And why is that important? Well, it's because we can stratify risk even in younger people, as you see here, looking at polygenic risk scores. And it makes a big difference because if we intervene early, we're going to reap greater benefits. We can see that the duration of exposure to LDL relates to outcomes, both in the left and then on the right. So earlier is better. And maybe polygenic risk scores will help us identify people at a very young age who need particular attention to lifestyle and perhaps in some cases, consideration for pharmacotherapy. So during my presidency of the IAS, one of my duties was to write for the newsletter every other month. And this was not subject to peer review, so I could just say whatever was on my mind without having to go through pages of comments from peer reviewers. So I wrote this one called Confessions of an LDL Hog. And to sum it up in just a couple of words, I make the argument based on my read of the literature that the LDL goal should be as low as reasonably achievable for many people and patients. And that's what I was practicing yesterday in clinic. And my own mantra related to this idea of targeting people in youth is lower for longer is better. So I'd like to hand it over to Manfredi now, who's going to continue the conversation about primary prevention.
Yes, my personal greetings from Italy. Thank you so much, Professor Libby and Dr. Michel, for, it's a great pleasure to be with all of you. And I will continue discussing about primary prevention, which is of great importance for atherosclerotic cardiovascular disease to the fact that we can modify significantly such a risk. Indeed, both the duration and the magnitude of high LDL cholesterol levels, these determine the risk. And when we discuss about primary prevention of atherosclerotic cardiovascular disease, we need to emphasize the importance of screening, the risk assessment, and addressing the so-called modifiable risk factors. And this is strictly linked to an healthy diet, to lifestyle, to LDL lowering medications, particularly for high or very high risk subgroups. But let me also emphasize that screening should not wait clinical manifestations. This is a very important point, since in our everyday clinical practice, we may have individuals that lack symptoms despite a considerable burden of atherosclerotic cardiovascular disease. So the message here is that we cannot waste any minute. We need to take this responsibility and to promote screening as much as possible. And regarding routine blood testing, yes, indeed, we can easily access LDL cholesterol concentrations. We also have more refined parameters, such as apolipoprotein B. However, measuring ApoB, although this may offer some incremental value in the risk assessment over LDL cholesterol concentrations, well, measuring ApoB requires a more specialized assay, and this is not often available in our general practice. I can share that in Italy, ApoB measurement is usually confined to larger hospitals, to highly specialized labs, and indeed it's not so easily accessible. By contrast, we have non-HDL cholesterol that can be easily calculated by a simple subtraction from HDL from total cholesterol concentrations. So very easily we can calculate immediately the concentration of non-HDL cholesterol, and this parameter, it captures the information for all apolipoprotein B containing lipoproteins. And several international guidelines have highlighted that measuring non-HDL cholesterol concentrations, it's an alternative to ApoB measurement, and therefore has great benefit in clinical practice. And now I need to mention Lp(a). Lipoprotein (a) is an independent and inherited risk factor for atherosclerotic cardiovascular disease. It requires indeed a more specialized test, but it's becoming more popular, more available in our countries. So we are overcoming the barrier for screening the concentration of Lp(a). It's a single lifetime measurement may be sufficient since it establishes the risk due to Lp(a), since this parameter is largely genetically determined. And in addition, healthy adults should have indeed a cholesterol screening every 4 to 6 years. This is what we usually recommend for the overall population. But for certain subgroups of people, such as older adults or patients at higher risk, or those with a family history of elevated levels of cholesterol, we suggest that these subpopulations, they merit for sure a closer LDL cholesterol assessment. Regarding unmet needs and evolving landscape of primary prevention in atherosclerosis, I would like to mention this quote from our colleague, Dr. Viviane, who will talk in a minute. So she was highlighting that for risk factor management in childhood obesity, lipid profiles are seldom ordered. However, it is important to start monitoring very early, since we are talking about duration of exposure. And Professor Libby, just a few minutes ago, highlighted the importance of caring of the younger generations. And regarding prevention, there is also another pillar related to imaging. Indeed, many healthcare professionals, they do perform additional tests as imaging, and they also include first electrocardiogram or ankle brachial index test in order to assess cardiovascular function more deeply. But then imaging studies, they add a lot of information, and there is now becoming very popular coronary artery calcium score, or even coronary artery angiography. These sort of imagings are becoming very popular since they powerfully predict atherosclerotic cardiovascular disease events, and therefore they can outperform traditional risk factors in this context. In addition, in many countries, we see that ultrasonography is very popular, and particularly Doppler sonography in order to assess carotid intima media thickness. Yes, it is true that it requires specialized skills. In some geographical areas, this Doppler sonography is less widely used than direct coronary artery imaging when this testing is becoming more available. So we have basically several options, and for sure a combination of data from imaging can provide additional insights for our patients. Professor Libby was mentioning the importance of genetic testing, and indeed they may add a lot of information for our clinical management, particularly if there is a family history of atherosclerotic cardiovascular disease or cardiovascular events. So this is another very important option for proper management and potential treatment of our patients. And as a whole, these figures is summarizing what I was mentioning in previously. So basically, we have different types of screening tests, and these tests are helping us to assess the overall atherosclerotic cardiovascular disease risk. For sure, we start with the so-called lipid panel, and even with more specialized lipid measurements. Then we go to some assays in order to determine cardiovascular function. In this context, we use ECG or EKG, and even more, we have imaging tests available together with genetic testings in order to make better management of our patients. My last slides will be dedicated to risk assessment, which is a very important tool in primary prevention of atherosclerotic cardiovascular disease, as it is recommended in many national and international guidelines. Nowadays, there are for sure some challenges around the selection of proper risk factors, which risk factors to include, which risk factors to exclude. And there is a lot of debate since, just to give you an example, regarding diabetes. Diabetes is for sure considered one of the most important major risk factors, but we also need to consider that the presence of diabetes per se is elevating the risk for the formation and progression of atherosclerotic CVD. Therefore, it is always not fully clear how to select the risk factors. And in this context, we are learning that dietary fat intake does not always identify high-risk people. And in addition, another barrier is linked to the fact that some of the risk factors, they vary between countries, between regions. Professor Libby was mentioning the importance of overweight and obesity, even more in younger populations. And we know that even if this is now becoming a global problem, there are certain geographical areas that are more affected by overweight and obesity. And inside specific regions, certain countries are more affected by such risk factors. And therefore, this is something to consider when we evaluate the global risk assessment. In this context, a few years ago, in 2023, the American Heart Association released a scientific statement on the need to move beyond the individual risk factor management, and therefore encouraging a more comprehensive risk assessment. And this statement highlighted the importance to assess a cardiovascular kidney metabolic cluster. It is becoming now very popular, CKM, as an acronym to assess cardiovascular disease risk. And this is also linked to the very successful management of risk factors that we can use in our clinical practice in order to reduce the risk of cardiovascular events by at least 50%. And so the message here is very clear that if we are focused on managing risk factors, we can reduce dramatically the risk of future cardiovascular events. However, we need to consider that so far only a small proportion, a small percentage of only 20% of patients, they reach in real life the targeted reduction in key risk factors such as lipid levels, blood pressure, blood sugar levels. So the message here for me is very clear. So we can do a lot to our patients if we are dedicated to risk assessment and prevention, we can give to them a longer and healthier life. And I will conclude my presentation with this slide. So we are comparing here two very common CVD guidelines. On the left, in orange, in yellow, we have the American College of Cardiology, American Heart Association guideline on the primary prevention of cardiovascular disease. So this is an USA guideline. And on the right side, in red, we have the European Society of Cardiology guidelines on cardiovascular disease prevention in clinical practice. So here we are referring to Europe. And the red arrow is highlighting the screening recommendations given by these two different guidelines. So the USA guideline, they promoted the importance of biomarkers such as C-reactive protein, ApoB, Lp(a), triglycerides. So in the US, it was promoted the measuring specific biomarkers of risk. By contrast, in Europe, this guideline did not promote measuring biomarkers and recommended, by contrast, a greater use of imaging tests. So what is the message for me here? That we have very important guidelines with some heterogeneity. And I believe that the International Atherosclerosis Society, our society, thanks to Dr. Michelle Winokur and the team, we have this beautiful opportunity together to harmonize these guidelines and to give the best for our patients globally. Now, I stop talking and I will pass to my dear colleague Viviane to continue the presentation. Thank you.
Thanks, Manfredi. First, I would like to thank IAS, Michelle and Peter for the invitation and the opportunity. It's a great pleasure and honor for me to be here discussing primary prevention, which I think is one of the most important subjects in cardiology, because we can do a lot to prevent the #1 killer in the world. We know that despite all the reduction in mortality everywhere in the globe, or in most regions of the globe, ASCVD is still the first one killer overall. But ASCVD is a multifactorial condition, as said by Manfredi and Peter, and most of the risk factors involved in this condition are actually modifiable. And the good news is most of the modification in these risk factors can be done through lifestyle. So it should be very cheap, but it's not done properly. So to be more precise, here we have this data that 90% of cardiovascular risks arise from modifiable risk factors, and more than half of these involve lifestyle behaviors, including alcohol consumption, smoking, sedentary lifestyle, stress, and also an unhealthy diet. So I guess we can say without any doubt that diet and lifestyle management furnish the foundation or a major pillar of primary prevention of ASCVD. So it should be applied to everyone, not only the ones on high risk, but also low risk, intermediate risk, everybody. But of course, those with a greater ASCVD risk should adhere even more strictly. Here we have a summary of most lifestyle recommendations, like smoking cessation, healthy diet, stress management, weight loss, physical activity. We all know that this is not new, and there is a robust evidence actually showing that all of them are beneficial, right? But unfortunately, there is a huge gap between lifestyle guidelines, what lifestyle guidelines recommend, and what is actually implemented. And there are several reasons for that, for this huge gap. So first, all these interventions are population-level interventions. So this does not work for individuals always, due to different reasons, because of different ages, sex, socioeconomic status. So these are overall recommendations. So sometimes individuals cannot work on that properly. So maybe we should have recommendations that are more directed to each of these groups so they can understand better and maybe apply and adhere better. But I guess some of the most important barriers include lack of awareness of the association between lifestyle and ASCVD risk. This is shocking, actually, but there is a lack of awareness of this relationship between lifestyle and risk. Some people really don't know that lifestyle can really impact the risk so intensely. And this is part of health illiteracy, so health uneducation. So people really should be more educated regarding health, about cardiovascular health. And of course, all those barriers that we know, poor access to healthy foods, also lack of spaces for physical activity in workplaces. We know that people work nowadays long hours, so they really need to have reserved spaces in their workplaces so they can work out for 30 minutes or so before they get home. When they get home, they are gonna be obviously very tired. They are gonna have dinner and go to bed without any exercise. So all these are barriers that I guess are true for all regions in the world, of course, different magnitudes, but this is true I guess, in many regions of the planet, and are barriers to lifestyle proper management. But of course, lifestyle measures are the most important pillar, but many people still need pharmacotherapy, of course, for proper management of risk. So lifestyle measures may not be enough to attenuate ASCVD risk. So there are several medications, and of course, statins are the first-line drug treatment for primary prevention of ASCVD. No doubt that there are several publications, studies, meta-analysis showing that statins significantly reduce ASCVD risk in secondary prevention and also in primary prevention, including mortality. So statins are really a very important class of drugs to attenuate ASCVD risk. And they overall are very well tolerated. So they are tolerated by most people and can successfully reduce high levels of LDL cholesterol. So they may be enough as a drug in many people. But of course, we know that there are limitations and barriers to statin use. So there is a wide portfolio of lipid-lowering drugs that we are going to comment later. But I'd like to mention a limitation that there is regarding statin use. We know that statins can be used successfully and reduce cardiovascular risk in most populations that have been tested. But in the extremes of age, there is still space for discussion and debate. So in individuals that are younger and those individuals in primary prevention that are over 75, there is still space for discussion. So we still don't know exactly when to use, which dose and which goal should we apply to these individuals. So still a limitation in guidelines that mention these age groups as still warranting some considerations. And regarding barriers, unfortunately, despite the awareness that is getting better regarding statin use and its benefits, there is still there is still a barrier to statin use, and low statin adherence is still common everywhere due to several reasons, and we're going to mention some of these barriers. So first, there are many people actually that remain undiagnosed regarding high LDL cholesterol. So as Manfredi mentioned, this doesn't lead to any symptoms. So you need really to measure the lipid profile to know you have high LDL cholesterol, and this needs should be done periodically, right? Especially in individuals with high risk due to other reasons. So there are many people that remain undiagnosed about high LDL cholesterol. There are some people that even knowing about high LDL cholesterol don't treat, right? Also due to many reasons that include age. So younger people usually don't care very much about CVD prevention in the long term. Also, people with lower education, lower income, those who lack insurance coverage or have poor access to primary care services. So these are some of the barriers that limit statin use. And there are some people that don't lack education, they have access to care, but they still don't take statins because they are afraid of potential adverse events, adverse effects, or they have adverse effects. It can also happen, of course, although to a minority of people, and actually much less than it's vehiculated in the media, right? We know that registries that evaluate statin side effects deliver an information that is not true when we evaluate double-blind studies, right? So there is really a gap between what registries and double-blind studies reveal regarding side effects. And there are some people that just have an aversion or reluctance to use of statins. So there are several barriers to a proper use of statins. And I'd like to remember about this message that Dong Zhao mentioned. I thought it was very interesting. We need to remember that there is a different susceptibility to side effects, of course, depending on the ethnic background. So Asian populations usually have a higher susceptibility to side effects. So they may need to start with a lower dose. So this is also important to be considered when we initiate a dose of statin or we intensify statin therapy. Now, I think it's important to mention about a wide portfolio of lipid-lowering agents that we have beyond statins. Of course, some people really don't tolerate, or some people tolerate, but they need further lipid-lowering therapies. And fortunately, we count on several medications right now to help us to attenuate further ASCVD risk. So just a brief summary about these medications. We have bempedoic acid, that is an inhibitor of adenosine triphosphate citrate lyase, so an enzyme that is in the same pathway of statin mechanism. So, but it's a few steps earlier. So bempedoic acid inhibits this enzyme, so it's going to reduce cholesterol synthesis. It is able to reduce LDL cholesterol in around 15 to 25%. And it was already demonstrated that bempedoic acid is able to reduce cardiovascular risk, so MACE and even mortality, and the 3-point and 4-point MACE. Ezetimibe is a friend of ours that has been used for several years already. It reduces cholesterol absorption in the small intestine and is able to reduce LDL cholesterol either in monotherapy and also associated with statins, so around 18% as monotherapy to 25% in combination. There is the combination of both drugs, bempedoic acid and ezetimibe, so two mechanisms that are able to reduce up to 38% LDL cholesterol. There are also the PCSK9 inhibitors, so the monoclonal antibodies that block PCSK9. So by blocking PCSK9, they are able to upregulate, so increase the expression of LDL receptors, and they are very potent drugs, able to reduce LDL cholesterol in up to 60% on top of statins. Inclisiran is also an inhibitor, is an inhibitor of PCSK9, but through another mechanism, so in degrading the mRNA of PCSK9, so also a potent drug able to reduce LDL cholesterol in up to 52%. and there are the bile acid sequestrations, which are polymers that bind to bile acids in the intestine. But unfortunately, a drug that is safe but has a lot of side effects, gastrointestinal side effects, and not very potent drugs, but can also be used. So, sorry, just a problem here with the slide. It's not connecting. Just need the next slide if I can pass on to me. Okay. So just my final slide, in my final slides, I would just like to highlight that the barriers to implementation of preventive measures also are different across countries. We, in this white paper of IAS that I really invite you to read, it's very interesting, very complete, but some barriers are cited as examples in 3 different countries. We all are different, but have actually similar barriers. So it's very interesting. So, for example, in Brazil, which is my country, we have a huge public healthcare system. So it covers for everybody, but it's clearly underfunded. And unfortunately, prevention of CVD is not the primary focus, unfortunately, because it's the most important cause of death here in Brazil. So it's not the focus. In India, also, there are huge competing priorities in health system, like control of maternity and child mortality, also infectious diseases. So CVD is also a secondary target. In Italy, of course, Manfredi can talk about it much better than me, but there is I guess a higher awareness about it, and with more availability of lipid-lowering treatments, but it's still maybe combination is still underutilized. Combination of drugs to reach better LDL targets is still underutilized, because this is also part of Europe data. We still have a lower attainment of goal despite the availability of treatments. And we could talk also about other differences in terms of awareness, affordability, and availability of care, and also adherence. These are different across countries, but I can say for sure that awareness still needs to be improved everywhere. In our countries here, but also in other countries everywhere in the globe. Affordability, I guess I can say safely that statins are available everywhere, maybe not all statins, and maybe not all the lipid-lowering treatments, but at least one statin, like simvastatin, like not a higher potency drug, like, for example, in my country, but there is availability of statins. So the doctors could really use what is available more properly. I think it's still lacking. And adherence. Patients, because of the reasons we just mentioned, don't adhere properly. So we should try to improve not only adherence to drugs, but also adherence to lifestyle, as we just mentioned. So with that, I finished my part so far, and I pass on to Peter to continue the presentation. Thank you.
Well, hello. We're running out of time, but I just want to summarize a few of our challenges. We have these hurdles. We've heard about clinical inertia, adherence. We have to address disparities, and we have to worry about excess and affordability, all points which we've touched on during this discussion. And the answer is to assemble multidisciplinary teams that will help us to address these problems, and also to think about international cooperation. So with that, I'm afraid that we've run out of time, and we have to accord more time for questions going forward in the future. So thank you very much to all the speakers, and to our audience, and to the International Atherosclerosis Society for providing this platform. And let's work together as an international community to overcome the challenges that we've discussed today. Thank you very much.
Thanks. I think as Dr. Libby said, I think we've gotten really close on time. Perhaps we can offer one quick question and then we'll answer some of the other questions, perhaps via social media accounts, because some great questions have come in. And so maybe there was several around different types of risk calculators that came in, particularly asking about how to apply the proper risk calculators for your population. So I don't know if maybe Peter and Vivi, you would want to take a chance at mentioning those, thinking particularly about Hispanic or Latin American populations. Is it best to apply, or which risk calculator is it best to apply for this population, the European or Northern American, or do you have another recommendation?
Vivi, do you want to answer that?
Okay, sorry. Yeah, unfortunately, we don't have a calculator that is really validated for our population, like specifically validated for our population. But the calculator that was mentioned by Manfredi, it seems very interesting to us. We are actually updating several of our guidelines regarding treatment of cholesterol and also hypertension. And I guess with the increasing importance of obesity also in our population, and of course the importance of chronic kidney disease, as mentioned by Manfredi, we are really inclined to start using the PREVENT calculator, but unfortunately it hasn't been validated in our population. So we are still waiting for some of the cohorts, Brazilian cohorts, Latin American cohorts to evaluate this calculator. So we can have something more calibrated.
A question came in regarding HDL measurements. And could you very briefly tell us your view about the utility of HDL measurements in primary prevention?
Yes, thank you so much. So this question is quite stimulating, since they were reflecting about the subtypes of HDL, and I will extend also to LDL subtypes. It's stimulating since when we do when we assess the concentration of LDL and HDL, we assess the quantity of these lipoproteins, but unfortunately we do not have any information about the quality. So if we are able to assess in addition the subtypes of HDL or even LDL, so we are able basically to quantify both the quantity and the quality, so concentration and quality. This has a great relationship with cardiovascular risk. Very briefly, for HDL subtypes, we know that there are some specific subpopulations of HDL which can be dysfunctional and pro-inflammatory. Regarding LDL, we know that some subtypes can be particularly atherogenic, such as small dense LDL. They are strictly linked to the formation and progression of atherosclerosis. So assessing the subtypes can be extremely beneficial for our patients. However, in clinical practice is not so easy, since only specific laboratories can clearly assess these subtypes. So at the moment it is largely confined to clinical research, but our hope is to extend these use in our everyday routine practice.
So I have a couple of little comments on that. One is, in primary prevention, I think that measuring subtypes really dilutes the message that it's the LDL that counts. So I would encourage people who are doing primary prevention to ignore subtypes. It's not important for what we do in practice. Focus on the LDL. And with respect to the HDL, there's a danger in even measuring HDL, because some primary care physicians might think that if you have a high HDL, it protects you from the LDL. This is not true. The data that we have today shows that HDL is not protective. So I have a bit of a contrarian view about these matters in primary prevention.
Well, thank you all for your comments and getting in one comment about different questions. Obviously, a lot of other questions came in. As I mentioned, we'll try to answer some of those. We'll do a follow-up to this webinar on our IAS social media channel. So look for more answers there. And thank you everyone for joining us. Peter, Manfredi, Vivi, thank you for your excellent insight today.
Thank you so much.
Thank you very much. Have a good day. Bye.
Thank you.